I think what I thought I'd do for this talk, this is the first time I'm giving this talk, I just thought I'd go through some of the guidelines that just seem to come up now and again, and yeah, just go through that in a kind of exam-oriented way. So, anesthesia guidelines, how to sound like you know stuff and back yourself with difficult decisions. Okay, the rules, we'll try to do as many cases as possible. I'll ask lots of questions. And you know, this exam again is about making decisions, so let's just get used to a lot of that today. Because everyone's just in their rooms, what I'll do, I'll just give you guys time to answer the questions out loud in your own environments, but I really just want to get you to commit to decisions, because that's what a lot of this exam is about. And funnily enough, real life is about too. If you answer well, that's fantastic, but if you don't, who cares? If you know something I've missed, please let me know. It'll definitely help me improve for the next group. Why did I go through guidelines? Well, I think there's one thing that I found really useful, back when I was a trainee especially, that everyone's got their opinion, but when you really believe in something that you need the patient to be managed a certain way, it just really helps the weight of your argument if you can just quote a guideline, because it's kind of like, I have my opinion, my consultant has their opinion, but the guideline's based on expert consensus of some of the top people in the field who've done, just so much systematic review of the literature and evidence. And plus they've got the weight of the expert consensus as well. So I just thought it was really useful to go through these. Also, knowing other specialties really helps us advocate for our patients as well. Maybe your expectation of someone's management plan was different based on the guidelines that you know, but cardiology might say something different. So I think it promotes having a very useful conversation when you know what their guidelines are. And so that's what we'll go through. A lot of these guidelines will be very cardiology associated. From the start, we're going to go through perioperative cardiovascular evaluation guidelines, and then some of these other guidelines. As expected, a couple of people leading up to the exams, this will be one of the bread and butter of leading up to the final ANSCA exam. So we'll go through this because lots of people haven't gone through this. But yeah, we'll take it for what it is. It could be a bit of a revision as well. This is that guideline, the 2014 ACC AHA guideline on perioperative cardiovascular evaluation and management for patients undergoing non-cardiac surgery. It is something that I'll refer to on a daily basis, and I'll think about quite a bit. So I thought it was obviously really important to go through. This is the really crazy flowchart that they've got, but I thought that we could make it a bit simpler. So my simple approach is this: every anaesthetist really loves morning coffee. And so that's the way I remember something that's pretty challenging, because this is pretty obviously what anaesthetists love most of all in the world. If it's emergency, you proceed. Active cardiac condition, refer. You check risk. If it's low, you proceed. Greater than 4 METs, you proceed. And then the final one, will testing change management? Yes, then you can continue with cardiac testing. No, continue with surgery. But let's go through that in a bit more detail. With emergency surgery, I'm gonna just ask someone here, what do you do? What's your principles for if someone comes in with emergency surgery, regardless of their cardiac status?
Well, you're going to take a full history examination and review investigations, but if it's truly an emergency, you've got very little time to optimize. So, generally speaking, this isn't really an exam answer, but I would proceed.
No, that's good. That's a good exam answer.
With sort of proceed assuming the worst with the most cautious anaesthetic.
Yeah, and I'm going to say absolutely. There's no time for thorough evaluation and management. So you just optimize, as you mentioned. You take your history, you find out what's going on, and you try to make things as best as they can. You increase your monitoring, and you crack on. And that's really refreshing. It's almost like easier to get an emergency surgery case having a heart attack, in the sense that, well, you've got no choice. You've just got to crack on and just make the best of what things are. The ACC AHA guidelines actually go on to classify the different scales of emergencies, but we'll go through that in a second. Actually, I'm going to ask Priya, do you know the different ranges of urgency?
Is that literally the emergency, urgent, or time sensitive? It's Kate. Sorry, I'm just trying to get my video on.
Yeah, go for it. What do you think of that?
Yeah, I in my memory, there's emergency, which is the life or limb threatening, so you have to proceed immediately or within a few hours.
Yes.
There's urgent, which is sort of life-threatening, but not so time-sensitive, so within a day, and then time-sensitive, and I think that's a couple of weeks.
Yeah, good.
You're referring to?
Exactly, and so that's important, because it's the first time we all knew this. Like when the 2007 guidelines came about, we knew that there was different categories of urgency, but this is the first time they've actually quantified what this means. So give me an example, Kate, of something that's in the urgent sphere. We know what super emergency is. That's AAA ruptured, going in spite of having an AMI on the table, you still crack on. How about urgent? What's an example of an urgent case?
It's a bit tricky because most things I'm thinking of vascular are almost falling to 6 hours.
Yeah, sure.
I think potentially maybe a bowel obstruction.
Yeah, maybe. I think that one that comes up over and over again is a NOF for me. NOF seem to be pretty urgent. Like you want to get it within the 24 to 48 hours. How about the time sensitive? What's an example of that? I'm also thinking time critical or time sensitive can be up to a few weeks, in which case to me it's like malignancy surgery, cancer surgery. Now, these new guidelines don't talk about active cardiac conditions in the same way as the older 2007 guidelines. The new ones just talk about like acute coronary syndromes, but I think it's really still very useful. So I want you now to speak to yourselves. I want you to come up with as many active cardiac conditions as you can. So take a minute to do that, okay? In the old guidelines, it literally talks about these. By the way, MI, absolutely. Less than 60 days is kind of that high risk period. Unstable or severe angina, decompensated heart failure, or maybe even a severe grade like NYHA4, severe valvular disease, severe aortic stenosis, symptomatic MS they call it, and then significant arrhythmias, so very slow stuff and your fast stuff. What's low risk surgery?
My definition is surgery where a combined risk of MACE is less than 1%.
Mm-hmm.
I think there will be, for example, things like cataract surgery would be a classic example,
Mm-hmm.
or some peripheral plastic surgery.
Yeah, absolutely. And is there an instrument, let's say it isn't those kind of very peripheral surgeries, lumps and bumps, cataracts, breast lumps, scopes, endoscopies of any sort, is there another way you can find out the perioperative risk?
I think there are various criteria. I think one classic one would be the Lee revised cardiac risk index,
Yep.
Which comprises of 6 criteria.
Mm-hmm.
One of it is surgical criteria, which is a suprainguinal vascular,
Mm-hmm.
intraperitoneal or intrathoracic surgery,
Mm-hmm.
and the rest are sort of patient risk factors such as, let me think, I think it was ischemic heart disease.
A history of ischemic heart disease, yep.
Type 2 diabetic requiring insulin requiring diabetes.
Yep.
Chronic kidney disease with I think creatinine more than 178 micromoles per liter.
Mm-hmm.
And heart failure, I think was the other one.
History of heart failure and history of cerebral vascular disease, yeah.
Yep, that's one.
Yeah, good.
Yeah.
Just to go through that briefly, and again, this was the first time that I saw the reference of this risk calculator as well. Having just to go through that, you're right. The Lee's revised risk criteria: ischemic heart disease history, heart failure history, diabetic on insulin, cerebral vascular disease history, renal impairment with a creatinine greater than 170, intrathoracic, intra-abdominal, or suprainguinal vascular surgery. These are the kind of criteria, and you're right, there's a surgical criteria and a few patient criteria. This is the first time they talked about this, the NESQIP riskcalculator.facs.org. So, plugging a whole bunch of numbers into that, it seems very comprehensive, but then there's still evidence about the risk calculator underscoring the risk compared to, Lee's revised risk criteria as well. So just good information to have, and I think we were all pretty familiar with using that. Now, just to go to someone else. Actually, I want you all now to take a minute, just describe a MET. I want you to describe it in as much detail as possible. It's the ratio of work of the metabolic rate to the resting metabolic rate. It's a state defined by the Duke Activity Status Index rather than score index. And then you're right, so 250 mils per minute, which is roughly the 3.5 mils of oxygen per kilo per hour. And it's 70 kilo, 40-year-old male sitting quietly. So the risk is increased if unable to meet 4 METs, and that was literally just one really, really big study. So back in the old guidelines, it was a class 2B recommendation. But then the Duke Activity Status Index does talk about various activities. And the only ones I could find that were close to this 4-MET mark were walking at 5.6 kilometers per hour on a level, brisk, firm surface, and stair climbing at a slow pace, whatever that means. So where does this 2 flights of stairs come from? Does anyone know? Yeah, so it was a very specific study that wasn't referring to METs. It just looked at stair climb, looked at a very large number of people able to climb 2 flights of stairs, and they quantified everything. It was 20 steps, 6 inches per step, and then 4 blocks, and each block was a certain amount of distance. If you could do that, there was a decrease in mortality perioperatively. So that's where that 2 flights of stairs comes in, and people often then will kind of mix and match it with various metabolic equivalent data from the DASI index. So it's just good to know that that's where all that came from. But hey, it correlates well with perioperative survival. But I think, like a lot of us, it's very hard to just have a bit of a conversation to really know how many METs someone is able to do, because they'll be very optimistic about certain things, and others might not be as optimistic or active in any way. And as a lot of our elective joints can't actually walk just because of pain as well. So it's very difficult to quantify this. Where would you get METs from if you could quantify? What a couple of tests you could use?
Cardiopulmonary exercise testing. So you're looking at anaerobic threshold and VO2 max, and usually an anaerobic threshold of less than 12 mils per kilo per minute is associated with increased perioperative risk, which roughly equates to your 4 METs if you do 3.5 times 4. It's VO2 max 14 mils per kilo. That's
yes. Because VO2 is pretty much exactly related to your METs. Good. Also, your stress tests your cardiac stress test will also give you that as well. Okay, so the final step there, will testing change management? If yes, go to cardiac testing. If no, continue with surgery. And realistically, almost always the answer is it could change management, because there's so many minimally invasive techniques for everything these days. So, practically speaking, you'd be well in your rights of arguing for testing if you're at the very bottom of this guideline. Every anaesthetist loves morning coffee. If it's not emergency surgery, if there's no active cardiac condition, if it's not low risk surgery, and they're unable to achieve 4 METs, you're almost, you're very well defended with going ahead with cardiac testing for almost any situation with those provisos.
Coffee,
yeah,
the C already.
The C, yeah, we're at C already. That was quick, wasn't it?
Oh yeah, it was.
It's just the easiest set of steps, really, and they're actually up until the very last step. It's pretty well evidence-based. Like, we're in the realm of either bloody obvious with the emergency surgery, expert consensus one, but minimal evidence because no one's going to test it, all the way down to the METs is probably, I forget if it's, that's right, the METs is 2A and 2B depending on that. Actually, I better get this right. It's pretty good. Like, if you can get excellent METs greater than 10, that's class 2A. That's a pretty decent recommendation. 4 to 10, it's still 2B. It doesn't have the most amazing evidence. Anyway, let's just go through examples, because I think that's where all the money is, really. One of the examiners told me back in the day he would just love to have a conversation during the medical viva who could just chat about the ACC AHA guidelines in a reasonable fashion. Like, that was the bar we're setting. That's what this will be about. So let's go through this quickly. 68-year-old with non-STEMI 2 weeks prior, ongoing unstable angina, high-speed MVA, free fluid in the abdomen, and the surgeon wants to proceed to theatre urgently. They're having a non-STEMI.
So this patient is a high-risk cardiac patient, but also this is an emergency. They're probably bleeding into their abdomen, and they need an urgent trauma laparotomy. So we would proceed with caution, with a higher level of monitoring, and with appropriate post-op disposition.
Yeah, sounds good. What would you do, practically speaking? Just make any assumptions you need. What do you do to supervise your management to make this as safe for this patient as possible?
Sure. So I guess we would obviously increase our level of monitoring, which we probably would do anyway in this sort of situation. So an arterial line, probably 5-lead ECG monitoring as opposed to 3-lead, contacting cardiology, contacting intensive care. and maybe monitoring post-operative troponins, but I'm not sure if there's anything that we could necessarily optimize immediately prior. We would be doing a cardiostable induction, etc., but that would be standard for a trauma patient anyway.
Sounds good. Now, the one thing I'm going to ask you then is, everything you said I completely agree with. Let's say this patient, high-speed MMA, free of fluid in the abdomen. When we talk about myocardial ischemia, we're always talking about, supply-demand. How would you optimize that in this situation?
Sure. So I guess maintenance of oxygen delivery to the heart. So make sure that their hemoglobin is adequate. So transfuse earlier rather than later. Ensure that they've got adequate blood pressure, I suppose. So maybe permissive hypotension is not necessarily something that you would do for this patient, like you might for other trauma patients. And avoiding tachycardia as best possible to increase time spent in diastole.
That sounds good. Excellent. So outline, transfuse, analgesia, reduce unnecessary tachycardia, and I'm always thinking myocardial oxygen balance, delivery and supply. Next one, fractured NOF, multiple comorbidities, including ischemic heart disease, AF, and unknown exercise tolerance. Currently in pain and signs of fluid overload and mentally alert. What do you do with this case? It's probably worthwhile, everyone just taking 30 seconds to a minute, just stepping through every anaesthetist loves morning coffee. I want you to have that just really in your minds, because that's the best way, say in this exam or even in real life, you can communicate to other people exactly where your thoughts are. So just take 30 seconds to think about that, make a call.
Would you mind skipping back to the slide with every anaesthetist loves morning coffee?
Yes, I can do that.
So I can quickly...
Yeah, absolutely. Actually, everyone take a photo of this slide, or these two slides maybe. Because literally, when we're going through these cases, you will just go through each of these steps, and once once you're at the appropriate step, then you get off the train. You don't need the guideline anymore. And the other mnemonic was every anaesthetist really loves morning coffee. I'm really proud of that because I made it up myself. Can't hear anything.
You might have just changed my life with this situation.
There you go. That's what I want to hear in this talk.
This morning could be absolutely massive.
Come on, Joe. Oh, now you're pandering.
And
so this is time dependent, but there is an active cardiac condition. Again, there's fluid overload, which is presumably decompensated heart failure.
Yep.
So there's something that could be optimized within the time frame.
Absolutely. And I like that you said you picked up on that. Because fluid overload, what would you give to this patient just as it happens?
Presumably Cruisermite.
What are there's a few things with fractured NOFs that you could optimize, that are often things that happen, like in our experience, we get a fractured NOF. It's often a few of these things. What are the things in your experience can you improve in that kind of 6 to 12 hour mark?
So fluid overload is the major one.
Yep.
Sepsis is a common
co-presentation
you can improve. Anemia.
Yep. That's pretty good. I always see rapid AF every now and again as well. So rapid AF, CCF, severe sepsis, HB, these are easy things to treat in a hurry, I think, and you don't really have to delay for very long. You get the referral, you find out a few of these details, and then you can get the patient down into theatre and manage this while the other case is going. So, Look at this case, 70-year-old male with PR bleeding secondary to colon carcinoma, type 2 diabetic, cholesterol, hypertension, unknown exercise tolerance. Step through your guideline there.
In approaching this case, I'd be interested to know whether or not the PR bleeding is massive or if it's a slow PR bleed. For this patient, I assume that we're working them up preoperatively. And so I think that this is a time-critical surgery that does need to happen in an elderly patient with multiple cardiovascular risk factors who does require further cardiovascular testing for a high-risk procedure.
How long would you delay the cardiovascular testing before you crack on with this surgery?
So from this stem, I'm thinking that they will be having a bowel resection. So obviously correct me if I'm wrong.
Yes.
In doing cardiovascular testing, I think it would change management in that if this patient has significant cardiovascular disease, we may not offer them cancer surgery, and so I think it would alter management. However, I would expect that I'd want to get cardiovascular testing done within a week.
Okay. Where does this fall in the guideline?
In terms of the time critical, or?
Yeah, time sensitive, yeah. So,
Yeah.
I mean, the guidelines would say, if it's time sensitive, proceed. That said, you know, you can make an argument for anything. When I step through this in my mind, and this is, you know, again, just my opinion, I would, as always, and as you mentioned, you know, we'd consult all the teams and, you know, check with cardiology and the treating team. You want to know how aggressive the cancer is, and there's a lot of factors to consider. But when I think about it, either way, you know, the cancer is an invasive colon cancer. I need to get this done, and I'm thinking, what could I possibly do in that time to change this? If you can get a stress test or whatever it is in the right time frame, maybe adding more information will help you make a case for HD or ICU. So maybe it could be useful. Maybe you know, if you do an angio, maybe instead of stenting it, you could, you know, just do a plasty, if that's still a thing. Again, cardiology will know the best point of action there. But, you know, in another sense, if this was going to be delayed in any sense, I think most people would say you just have to crack on here. Now, that's just my opinion, Ali. So, you know, I reckon ask as many of your colleagues and just get an opinion about this particular case and see, you know, would you go for testing? And if they all say what you say, great. If they say what I say, you know, then it's something to rethink. But also, it'll be interesting to if there is good evidence about whether you should get testing in this situation that you might know of. Hope that all made sense. Yeah.
Can I just clarify with this patient? Unless I guess you would have. I think we're at the third step of your acronym here, looking at risk, a risk calculator.
Mm-hmm.
So looking at what you've given us, if there's an absence of any other of Lee's revised cardiac risk index, they score 1 for intraperitoneal surgery,
Mm-hmm.
high risk surgery, as long as they're not on insulin, and therefore they would be deemed low risk, under 1%, based on old in hospital MACE percent rates. So therefore I would proceed. I don't think then I would go, and then like you would be reassured by a good exercise tolerance.
I would look at it a slightly different way, as in, I agree with your argument. I would put it in the E, every emergency surgery category, but when I proceed, I would also I'd also, you know, plug the numbers into the risk calculator to see, you know, what the risk of this patient going to surgery is. That's probably semantics, so that's just a technicality of where we stand in that guideline. But yeah, this could very well be lower risk than I perceive.
I mean, in terms of deciding if it's time-sensitive surgery within, you know, 6 weeks is what you've told us, right? Then if you're deciding if 1 week versus 6 weeks,
Mm-hmm.
I would say, like, yes, it is emergency. We need to do it within 6 weeks
Mm-hmm.
based on the criteria for time-sensitive cancer surgery, as long as the patient's not hosing blood.
Uh-huh.
And so therefore, what is the time to optimization? And that would probably depend on the risk index and then the METs. And then you can decide whether testing will, that's how I would think, that's how I think of these kind of cancer-y ones.
Yep.
Because obviously you have to proceed, but you have 6 weeks based on what we've spoken about.
Actually, maybe that's where I should have been more clear. The definition includes, I think, up to 6 weeks, but then in my mind, I would have to clarify the urgency of this. And so in my experience, most aggressive cancer surgery has to be done within 1 to 2 weeks. So I didn't highlight that time frame, so apologize for that. I would do everything I could in that 1 to 2 week time frame, but I'd most likely proceed.
Yep, cool.
Cool.
Can I just ask at the
Please.
risk of
No, not at all.
opening another box? So it seems very much that people kind of just focus on Lee's revised cardiac and risk index, Darcy's METs, and all the rest of it. You know, in the UK, we're doing a little bit more with PPOSMs, National Emergency Laparotomy scoring systems. There was a UK one, a Scottish one that had different, and they all had their own kind of like multi system type, you know, input to pump out a couple of numbers at the end in terms of inpatient morbidity and mortality.
Yes.
So is there any kind of point bringing those up? Are they kind of there's too many nuances to those to kind of really?
I think it's a really good question. There's a whole bunch of risk calculators. I would just go with whatever's appropriate. Like let's say this is a question about perioperative risk. I'll just use the risk calculator and show that I know that, or I'd use something I could do on the fly with like Lee's revised cardiac index, so I can give a number on the fly. If the question is then about risk calculators and perioperative risk, which I don't think that's something that a lot of anaesthetists necessarily talk about. I think it's very ICU. Then I would get into the knowledge of Possum and Apache and all the other scoring systems that have ever existed. But I wouldn't feel the necessity to bring it up if the question was not about perioperative risk per se and more about the decision to proceed or not. What do you do with this case?
This patient is an elderly patient with going for a low risk factor. This patient had an atrial fibrillation that need an adequate heart rate control before we just proceed. So I would just control first with.
So and Louis, so where are you at with this in the guidelines?
So basically, this is a low risk factor. So low risk surgery for a patient who had
just to step through. Is it emergency?
It's not an emergency.
Great. So it's active. So is it an active cardiac condition?
It's an active cardiac condition.
Beautiful. And so you stop there, right? Active cardiac condition. Maybe the next question I'll have, just to make it a bit more complicated. What if this patient had potential biliary sepsis? So now you've got a patient who's septic with a rapid heart rate. What would you do then? I've just changed the scenario from elective with an active cardiac condition to now more of an emergency. And that's why you'd be right to say, look, the heart rate, this is probably a more urgent case, and I might have chronic AF at a rapid heart rate because of the sepsis. After trying all attempts at beta blocker and amiodarone, or trying to decrease the heart rate and stabilize this patient, I have to continue. So I proceed then. Okay, let's just go on with this one. 60-year-old female for laparotomy with incisional hernia repair. The patient has rheumatoid arthritis, and you notice a systolic murmur.
I would want more information based on the STEM in order to properly stratify. So we've got what we know is
just for the exercise. For the exercise, I want you to all go through the steps of the guideline. So, is it emergency? Is it active? Just so everyone can then see your rationale.
So, from the STEM, I am trying to work out whether it's emergency or more time urgent. Or
okay, sorry. Let's say it's elective.
Okay. Yeah. Then, so assuming this is an elective incisional hernia repair, so the patient's not having any bowel obstruction or strangulation symptoms. She's got known rheumatoid arthritis with expected implications on anesthesia, and one of them being aortic regurgitation, and we also notice a systolic murmur. Now the quantification of, so she has a possible, in terms of active cardiac disease, she has a possible active cardiac disease.
Great.
We still need to note up.
What do you want to do?
I would assess the patient through history, exam, medication, and investigations, and with specific focus on exercise tolerance, looking for signs of heart failure, and examining doing a full cardiovascular exam, looking for trying to define the murmur, and then at the end of it, order an echo.
Good. Okay, so let's say they have no signs, good exercise tolerance, no signs of severe aortic stenosis, no heart failure signs.
So ECG as well.
That's fine. What do you do? You don't have an echo with you. Do you? Let's say an echo is a week away.
Yeah.
No signs of heart.
You said normal. So
normal examination, no signs of heart failure, no signs of a bad valve. What do you do?
Okay. That being the case, given the reported good exercise tolerance is reassuring. Having said that, there's gradients of how much I would believe that based on the previous MET trial. Given that this is an elective surgery, and the chances of her having, I think I would counsel her to consider waiting for echo.
Okay, so and it's good that you get consent from the patient, but we're here to make decisions, and and let's say and the patient's just happy with what you say. What would you do in this situation if you were them? Let's put it that way.
I would proceed cautiously.
Okay, but this could be severe aortic stenosis, couldn't it? It's a systolic murmur.
Yeah.
Are you sure?
I guess based on the assessment, if she has very good exercise tolerance on her history, like she runs and swims like multiple laps, or if she's got and based on examination of what her blood pressure is during you can make her do some office-based exertion and then take a blood pressure to see whether.
And Angela, so what I'm going to get at here is that I want you to take a far shorter time to come up with a decision, because you don't need to go into so many things. Like I think you know what to do here, and you could do either. Okay, I just want you to now at this point go. This patient's got great exercise tolerance, no signs of heart failure, very, very, very unlikely to be severe aortic stenosis. I'm going to crack on. Or look, it's elective, it's a systolic murmur. It could be severe. I'm going to get an echo. There'll be, and again, this is my opinion, but there'll be plenty of people doing one or the other. And it's for this exam, it's your job to kind of find where normal is. But I suspect that you could go ahead with either. It's almost like the only problem with your answer is the time you took to discover your decision. That I would say that would be one of the only problems with this answer, and I appreciate that for what it is. So a 50-year-old male, inguinal hernia repair with trifascicular block with multiple fainting episodes. Next person along, BJ. What do you reckon? What do you want to do? Just stepping through the process we've gone through.
So this is an elective procedure.
Yep.
I have an active cardiac conditions in the form of syncope with the trifascicular block. So I would like to refer for multidisciplinary team, including cardiology, and discuss with the surgeon about the urgency. If any strangulated or it's not strangulated. Then I will also simultaneously risk stratify and ask for other.
BJ, that's perfect. That's all very good. Actually, I'll give you this next one as well, just to keep moving. 78-year-old female, BJ, recent echo showing moderate aortic stenosis for cataract surgery. This patient's unable to walk up a flight of stairs due to arthritis. What do you do?
This is again elective case according to my checklist, but moderate is, so I need to quantify the risk. And I will also take the multidisciplinary team members to find out about the possibility of exercise tolerance, or could be a total pressure to quantify as well as simultaneously the risk.
So BJ, you've said it's elective. Is it an active cardiac condition?
Yeah.
Moderate
is. There is no active cardiac conditions.
Good.
What I feel.
So if it's not active, then I go down to, is this low risk surgery?
Yeah, it is a low risk surgery.
So why do you need? So then, do you proceed or do you get an echo, or do you quantify stuff?
I can go either way at this point of time because it's a low risk, so less than 1% risk. So I can go ahead.
Perfect.
Because there is cardiac condition.
That's great. Next case along. 60-year-old. As you can see, I'm going through these quite quickly. The exercise we want to go through is just getting the basics of familiarity with this guideline, and you'll all appreciate that there's some real nuances if you delve into certain things. But I really want to get the base of everyone's understanding of these guidelines, because then after this base is just absolutely spot on, and it's like this backwards, then you can think about all the the differences in how you might approach certain situations. Because at the end, being a consultant in real life with real patients and real surgeries is a very nuanced kind of environment to be in, And as we could remember with the, with cancer surgery, there's all different kinds of cancer surgery. There's all different kinds of risk, and there's all different patients with, different values of what they want to do. And I feel like the only way we get to that nuanced conversation is by having a really good base. And that's why, I guess we're going through this. So next case, 60-year-old male lap collie, unknown exercise tolerance due to back injury, nil past history. What do you want to know from this patient, or what do you do?
So this could either be elective or urgent if it's acute cholecystitis.
Let's say it's elective.
Sorry, how many?
Let's say it's elective, yeah.
So I've already got the history, no past history, so there's no active cardiac condition.
Mm-hmm.
Based on the revised cardiac risk index, this will give a score of 1 for, I guess, intraperitoneal surgery. No worries, I'll check that. But in any case, like a score of 1 puts you in low risk. So I would proceed.
I think you'd be very, very fair to do that. If you plug these numbers into the risk calculator, you'll also come up with a very low risk for the surgery, and lap collies are often done as day surgeries in many places as well. Very good. 60-year-old male, total hip replacement, AF 70, cholesterol, hypertension, obese, stays in bed most days and walks to the lounge to watch TV. Take 30 seconds, everyone. I want you just to step through this. Yeah, go for it.
So this is an elective case, not an emergency.
Mm-hmm.
It doesn't sound like this patient has an active cardiac condition based on the history, although I would want to determine whether that AF is decompensated in any way or if there are any sort of signs of
absolutely stable.
Examination.
Mm-hmm.
Stable AF, fantastic. So I think this patient, based on the RCRI, would be low risk.
Mm-hmm.
So I would proceed.
Yeah, and you'd be well within your rights to do that. I think a lot of people would see this as low risk, and that's fine. Walks to the lounge, watch TV, stays in bed most days. Good. How do you feel, Diane, about this one? 80-year-old female, total hip, NYHA2, ischemic heart disease, type 2 diabetes, AF, COAD, OSA, all stable and optimized. Walks every day, independent ADLs. Again, following.
I subjectively feel worse.
Yeah, that's right.
Just looking at that.
And just stepping through the guidelines again.
Yeah, sure. So again, this is elective. In terms of an active cardiac condition, if everything is stable, there are no signs of decompensation, then I think technically she wouldn't have an active cardiac condition. Her risk score, I think for age, she would get at least a 1. And is she on insulin or anything like that?
Yes, let's say she is.
She is on insulin, and she's got a history of ischemic heart disease. So I think her risk score goes above 1. So I would go ahead with cardiac testing.
What's the next step after risk?
Actually, sorry. Oh, it's about METs, right? Yeah. So she walks every day. So I suppose we just need to figure out how many METs she's capable of.
Beautiful.
So maybe give her a DASI, and if she fills that out and she's got greater than 4 METs, we could proceed.
Perfect, great. So I mean, at that point, the question I want to know is exactly what you said, which is, what are the METs for this patient? And in spite of all the past history and issues, they walk every day, independent ADLs. Chances are it's going to be good. So I'll ask that very specific question as to how good is the patient's metabolic equivalence, and then proceed if that's relevant. I've mentioned here all stable and optimized, just to know that each of these problems isn't just an isolated problem. Like you obviously have to optimize and manage OSA and have CPAP and have a tailored anesthetic, and same with COAD. But just to have that framework as a baseline, then you can tailor specific things about each condition on top of that. And that's how I think about this practically. Okay, total knee replacement, ischemic heart disease, diabetic, on insulin, let's say, NYHA2, CCF, previous stroke, or TIA rather, hypertension, cholesterol, and asthma, and has poor exercise tolerance.
So the lady for an elective procedure, if all of the comorbidities are stable, and with an NYHA class of 2 indicates their cardiac disease is probably stable, then there's nothing to kind of like refer onwards. So we've done risk assessor. She's at least 3 on leisure biased cardiac, so she's more than 11% chance of coming to some form of harm here. and we've got poor exercise tolerance. So probably go investigate her. So depending on what her function is from, I mean, I know she's not got poor exercise tolerance, but it's going to be a chemical tolerance test, looking for reversible ischemia.
What's an example of a chemical exercise tolerance test?
And so debuting echo.
Sounds good. And so this is obviously now at the lower end of things where we've gone through E, A, emergency, it's not active, it's not low risk surgery, we don't have a good idea of METs, and we're now at the point where we look for any cardiac testing and if it'll change management. And there's always the argument that of course it could change management. And I've just put here, what can you do if you need to crack on? And I think we've already mentioned it really. Urgent cardiovascular referral, optimize any disease state that you can. You step up your outline, and then post-op CCU or HDU with ongoing cardiology and medical management. How about this one, James? What do you reckon? 50-year-old for an elective inguinal hernia, active wheezing from asthma for the last week. What do you do?
It's an elective operation. So the things that you can do here, so you always got to consider whether you're going to do a general anaesthetic or a regional anaesthetic technique. So he may actually have chronically poorly controlled asthma. So wheezing for the last week may not be an event for this man, woman.
Yes.
And depending on the technicality of the surgery, the BMI of the patient, you can potentially consent him for it to be done under spinal anesthesia with no sedation.
Sure.
And just avoid any instrumentation of the airway, as long as it's likely to be a short duration and all of those things.
Okay. How about if this was now, I'm changing the scenario, 50-year-old with now well-controlled moderate asthma. It's been optimized, they've just had lifelong asthma on all the puffers and takes them regularly and is good. No recent steroid use, but has been hospitalized, every 5 years or so, but not within the last couple of years. It's for a lipoma excision. What do you do?
Where's the lipoma?
On the back. It's about 3 centimeters by, say, 3 centimeters.
Okay. I think a similar approach, obviously this is an elective procedure, so it looks like, if you treat it in a similar way, the cardiac, they're optimized as well as they're going to be. So you can look at risk stratification, and there's no formal risk stratification that we can do for this. It's probably going to be a joint discussion between the surgeons, the patients, and ourselves regarding the best approach. If it's on the back, then using a neuraxial technique is inappropriate. But if it's quite small, then we can potentially do it under local anesthesia, maybe with just a little bit of alfentanil just for the local going in, if they're particularly frightened of needles, or a general anesthetic, and then the things that we can modify on the day of surgery to reduce risk would be to do, a supraglottic airway to avoid instrumentation, as long as there's no indication for an endotracheal tube, like severe reflux. Using a volatile that's non-irritant and a bronchodilator like sevoflurane. Doing there's no evidence for pre-op nebulizers, but why not?
Yeah, that's good. Hey, James, so I think that's good. What I like at your answers, James, you cover a whole lot of stuff in a very short space of time, and that's really good exam technique. Your ability to speak quickly in this exam, I think, covers all manner of things. And so when I look at your technique, the only thing that I would say in front of an examiner is they won't be thinking as quick as you are. So it'll be very important, not necessarily in this situation, but in your exam situations, to flag your structures so that they know exactly where you're going, because I guarantee you they'll be too busy marking stuff to take all of it in. But yeah, that's great. So let's go through this one. 30-year-old from elective lap chole, known COPD, multiple exacerbations recently. What do you do?
So this is elective surgery. So we've got time to optimize this patient. Although it's not a cardiac condition, this patient has got an active respiratory condition that doesn't appear to be optimized based on the patient's symptoms and his recent exacerbations. So I'll be looking, I would be keen to cancel this surgery.
Beautiful, so you postpone?
Postpone.
It's now well-controlled COPD, what do you do? A couple of weeks later, let's say a couple of months later, it turns up to your list, now well-controlled, what do you do?
Crack on.
Yeah, nice. Good exercise tolerance. What I want to do with those last two cases, they're obviously not cardiac cases, right? They've got their own particular, respiratory bent. But what I want to say is that we can absolutely use the same algorithm for non-cardiac disease. Again, I really want to blow your minds with this. So the non-cardiac disease algorithm looks the same because emergency is logical, right? You have to proceed. Active disease state, again, it's logic. It's active disease state. You cannot go ahead with something you could optimize in an elective situation. So that makes just logical sense. Again, low-risk surgery, when they did when they looked at the evidence for low-risk surgery, the mortality perioperatively with low risk is low because of the fact that there's very minimal, physiological impact of a small cut or no cut or a scope or a cataract. So, regardless of how bad their heart or lungs are, they've at a very low-risk category for the nature of the perioperative, ease of recovery. Anyway, so I think this guideline really helps in every circumstance, cardiac or otherwise. So I just wanted to make that example with those couple of lung cases. Emergency, active disease state could be anything, acute asthma, ERTI, COAD, acute renal failure, liver, whatever it is. And then if it's not that, low-risk surgery proceed. If it's not that, greater than 4 METs, again, you'd be well within the logic and rights to proceed. And then finally, if you have none of those in your favor, will testing change management? Can spirometry help me diagnose this asthma? Can any kind of liver test or whatever test for acute renal failure change the pathology and improve things? And if yes, which often it can be, then continue with testing. Next question. Your 60-year-old neighbor has a non-STEMI. Needs a total knee replacement. When is it optimal to do this operation? I want everyone to make a call. What time frame does this patient have to wait? Take 5 seconds, think of a number.
I was thinking 6 weeks. For some reason keeps coming into my head.
Yeah, so the old guidelines from 2007 had 6 weeks as a number. We've got a different number now. So look, these current ACC AHA guidelines refer to the length of time being about 60 days, and they actually give pretty good evidence for this. So look at these mortalities. So look at these MACE rates and then 30-day mortality rates. And they've said that you essentially get this drop off at the 60-day mark. As you can see, MACE goes from 18.7 to 8.4 at 60 days. Mortality, really trails off after even 30 days, but at 60 days it's low, and at 91 days and onwards, it's not that much lower. So the time frame that they quote then is 60 days. Now this is also interesting because what I'm doing is I just want to give you this number, but there's more detail to this depending on what medications there are. And we'll go into that detail in a second, but I hope that this will give you kind of some good evidence and information to help guide your decisions. Because again, it's in this guideline. So the data suggests that greater than 60 days should elapse after an MI before non-cardiac surgery in the absence of coronary intervention. Obviously, PCI, drug-eluting stents, bare metal stents will change this as well.